Newberger, and on behalf of JOWMA, I'm thrilled and honored to welcome Dr. Sharon Stoll from the JOWMA board, speaking on the topic of medicine in a post-COVID world, which I'm sure you're all really, really interested in imagining and hearing about. I know I am, and I'm going to be listening with rapt attention. So Dr. Stoll is a board-certified neurologist and assistant professor of medicine at in the department. I'm sorry, assistant professor in the Department of Neurology at Yale School of Medicine. She completed her neurology residency at Thomas Jefferson University Hospital in Philadelphia and her Neuro-Immunology fellowship at Yale New Haven Hospital. Dr. Stoll continues to play an active role in academic development, continuing medical education, is an investigator on several international trials, and serves on several medical advisory boards. She has received numerous awards, including teaching awards, and is a grant recipient from the National Multiple Sclerosis Society. Dr. Stoll has been a medical editor at ABC News and is a medical commentator currently for several news outlets and shows, including very recently an appearance on The Doctors, which was incredible, and has served as a keynote speaker for the annual Women in Science Symposium. She's an internationally renowned speaker, patient advocate, and we're really excited to have you here tonight. So without further ado, take it away, Dr. Stoll.
Great, thank you so much for that wonderful introduction. Let me share my slides. And
actually, let me just add in terms of housekeeping, if anyone has questions as we're going along, feel free to type them in the Q&A chat box, and we can get to them at the end. If you want to ask them anonymously, I'm happy to go through and, pick out the questions without saying who they're from. So yeah, so you can use that as we're going through, and we'll take questions at the end.
Great. Thank you so much for that wonderful introduction, and thank you all for joining in today and listening. So it's crazy because when I was going through this slide deck, I gave a talk similar last year pre-COVID, and it's so scary because a lot of the slides that I had marked as future medicine is here and now, less than a year later, which is really, really scary. I gave a similar talk, Technology in Medicine, February 11th. And it's crazy how much has changed in a year. Here are my disclosures. And this could not be more true right now. And so medicine of yesterday, general practitioners, subspecialists, physicians' medical knowledge was trusted. I'm sure we all long for a time when that was still true, because unfortunately we live in a very different world now, where mid-level providers are replacing general practitioners. It seems like every day, as more and more general practitioners retire, 10 mid-level providers take their place. It's astonishing. And subspecialists such as neurologists or ophthalmologists are being replaced with subspecialists. And this is true for my field also. Neuro-Immunology, which is what I do, didn't exist probably 5 years before I went into it as a subspecialty. So anybody over the age of 50, if they do what I do, if they practice the same type of medicine that I practice, there was no fellowship training for them. And that's true for most neurologists. Neurologists used to be a specialty off of internal medicine. It wasn't its own subspecialty. And now you basically need a neurologist just to guide a patient through the neurology subspecialties. And I'm sure that's true for a lot of medical specialties now. And then the bottom bullet point, physicians are not trusted. Well, again, medicine of today, a lot of my patients come in and say, well, their friend or their group chat or their friend of a friend told them about a medication that they think they should be on, or their Google search told them that they should be seeing me. I'm sure everyone listening can relate or has a story similar to that. Again, media, everyone, I gave a lecture earlier today to pre-medical students, and one of the questions was, do patients ever get it right? Do patients ever come in with the correct diagnosis? And I said, yeah, if you have 100, just like any sample size, one is bound to be right. You flip a coin, there's only so many times that you can flip it, and you get a correct answer regardless of whether or not you know why. And again, so this was last year. So you can see my social media account. I also had Mimi's social media account, and I think she had 7,000 followers. I had 400 followers back then. One of the reasons I got into social media was to try and I'm sure a lot of reasons that a lot of people on this Zoom lecture got on social media was just to try and combat some of the misinformation out there, especially during COVID. And TikTok, I haven't gotten on TikTok yet, but that's the next step for me, I'm sure. Instagram, TikTok, Twitter, Facebook. I mean, I used to be interested in publishing in medical journals, and now I'm interested in publishing on Instagram. It's not about other medical experts in my field that agree with me. Now I'm trying to prove my own medical knowledge to my patients or the general public, which is, it's scary. It's scary that this is what physicians have to do now. Facebook groups, the joys of Facebook groups. I don't have to tell everybody here, the anti-vaxxers, the misinformation, and this is our healthcare now. This is what our healthcare has become, the medicine of today. Medscape, Healthline, the Goop Lab, and some of these things, again, I know a few people listening publish for some of these news sources, and I'm glad that they do. I work with Medscape and Healthline, and I'm amazed at how the writers get so much correct, and I'm glad that they use experts like myself and like those listening to get it to the next level, to make it really 100% accurate. It's scary that this is what we have to do, but I'm glad that there's some outlets out there that do work on publishing good information for the general public. So this was something that just started right before my lecture a year ago, telestroke. And it's much more widely available now. This is incredible. This is similar to telehealth. Telehealth I had on my medicine of tomorrow slide. But this was the medicine of today slide still. And this is something that it kind of reminds me of medicine of yesterday. So medicine of yesterday, 50 years ago, or maybe even more, 60 years ago, doctors went to the patient. We didn't want, or they didn't want, sick people in their waiting room infecting other people, or sick people trekking out 3 miles in the snow uphill, right, to see the doctor if they were sick. The doctor came to you. There's a lot of patients that didn't have access. They didn't have the ride that they needed to get to the physician, and the physician had the ride to get to the patient. And in that sense, physicians were much more accessible to patients. A lot of patients now, I'm sure other people know what I'm talking about when I say, they call you up after hours, doctor, I'm having X, Y, and Z. And you're like, oh my gosh, go to the hospital. What are you even thinking? Why are you even calling me? Like, go to the hospital. And then they have an argument with you. Well, I really don't want to go to the hospital. Can this wait till tomorrow? And they know it. Otherwise, they wouldn't be calling you at 3 o'clock in the morning. And the only thing that we can say is go to the hospital. But back then, the hospital kind of would go to them. So this is kind of taking it back to what medicine was back then, where the physician went to the patient. Only it's a computer. or it's a ambulance that goes to the patient. So they have these units that are capable of basically treating a stroke, an acute infarct. You have a CT scanner because the first thing you want to do in a stroke is make sure the patient's not bleeding, because the last thing you want to do is then give them a clot buster and make them bleed into their brain even more. So here you have a physician that actually able to examine a patient. You have a medic in the van that can do a quick neuro assessment. You have the CT scanner in the ambulance. The ambulance goes to the patient, and there's very few medical emergencies where you have a time window. Stroke is one of them. There's still a limited time. And in a place like, I almost want to laugh, like in New York, every 2 miles there's a hospital, but 2 miles in the city can take you 3 hours to get through. And if somebody has a stroke, if they're not getting that clot busting medication in 3.5, 4 hours, that's it. The time window used to be 3 hours. And if you're in the middle of nowhere, if you're in the middle of a remote village in Kansas, you're lucky if it's a 3.5 hour, 4 hour drive to a hospital that has access to TPA or a CAT scanner. So ambulances like this really save lives. And that's one of the good things that's going on with medicine today. Unfortunately, this lecture doesn't paint that rosy of a picture. The medical field, which I am still in love with, but like many relationships, we have our ups and our downs. And our down right now isn't because I stopped loving medicine or stopped loving treating patients. It's the bureaucracy, it's misinformation, and it's being pulled in every direction that doesn't involve patient care, direct patient care. So here's another example of medicine of today. This is like 3 steps removed from even seeing a physician. Although a lot of these medical apps are run by physicians. So there's one doctor that oversees the project. And then there's usually mid-level providers or fellows that prescribe drugs. So just show of hands. Let me see if I can't even see people. Okay, that's okay. Can I see hands? No. Let me go back. Can I go back? Oops. It's not. Oh, there we go. Okay. So these are apps that will prescribe patients or prescribe people common medications after you do a quick, answer a questionnaire with a medical history, what the issue is, what other meds you're taking, and then it'll give you a script, or they'll send you a script to your pharmacy without ever meeting the actual doctor. It sounds horrifying, but some of these things I'm okay with, like birth control, STDs, STI tests. I was actually Googling this a few days ago, and now on my pop-up on Instagram and Facebook, every other ad is an ad for STDs, which is awesome. I hope no one else is looking at my my search history or all of the STI and STD pamphlets and birth control pamphlets that I'm now getting. But that's okay. Hopefully it'll be filled soon with shopping ads like it usually is. But it's great because if somebody doesn't have access to a primary care physician, like a lot of young, healthy people do or don't, this is a great way to get birth control instead of going to the CVS and getting the morning after pill every other week or however often, or you're scared to go to the clinic, or you're scared to go to your primary care, if you even have a primary care, to get an STD check. So some of these apps make it much more accessible for patients that need it when they need it. And some, like the migraine ones, I used to have more of an issue with, but now there's great migraine medications that are safer and more effective than Tylenol and Advil. And as a neurologist, I see way too many patients that are on chronic NSAIDs or chronic opioids, and that can cause way more problems than these other medications that are available. So a lot of these things, they're common issues that people have. And unfortunately, now what's not common are primary care doctors. There are no primary care doctors. I think the pandemic pretty much closed down the offices that were separate from hospitals or large academic institutions. And before that, in 2014, when a lot of the older primary care and internists had to switch to medical records, to electronic medical records, that was like the first wave of retirement for the older physicians, and because they didn't want to learn a new system. And now with this pandemic, I think, 65 and older, that this is like the rest of it. And now there's this huge shortage, and in come the mid-level providers. And I'll leave it there. So here's some more apps that we use. A lot of these are multiple sclerosis apps. I wrote a paper and presented on all of the different MS apps that are on the market, and it was mind-blowing how much was out there. Not misinformation, just what's available for patients. And you almost need a physician just to walk patients through what they should be doing and what they shouldn't be doing. This is an app that I've actually worked on. And I don't want to say it replaces a physician. I'm not developing something to keep me out of work. But it's something that allows patients to be monitored closer. So like many subspecialists, we don't have time to see all of the patients that we want to and get them seen quickly. So if somebody has an acute MS relapse or exacerbation, typically we want to see them that week. But if we're booked for 3 months, how can we do that, right? And then the other issue is you really need to keep a close eye on certain patients to know how they're doing on a certain medication. So either you're telling them to follow up once every 6 weeks initially, or once every 3 months. But a lot of patients come to see a subspecialist, they'll fly to see me. I have patients that I have a patient that I treat in Poland. I have somebody that I treat in Germany. And I'm sure there's lots of subspecialists that are on the line also that have patients that travel from far away to see them. And we can't see them as frequently as we want to. So how do we do, especially in neurology where the exam is so important, how can we keep a closer eye? So this is a tool that I helped create that basically with a smartphone can monitor somebody's neurologic function. One of the things I'm sure a lot of people listening are aware of is just dementia. Somebody getting worse with time. And by the time they do get worse, it's usually too late. One of the reasons, I don't know if everyone's up to date on what's going on in the Alzheimer's world, but everyone, or at least all the neurologists or anybody that has a loved one with Alzheimer's, was waiting for this drug from Biogen to get approved. And it was just not denied, but had to take a step back. And I'm sure everyone's wondering, I know I'm still wondering why it's taking so long to make a good medication for Alzheimer's. It's a disease that way too many people have in this country. I mean, if I can't even count the amount of blood pressure medications that are available. And trust me, people are working on Alzheimer's medication. One of the issues is by the time it's diagnosed, it's already too late. If it's something that you can pick up early on, there could be a way to save the brain. With multiple sclerosis, one of the things that I focus on is saving brain. As a neurologist, that's like the first and foremost thing that we're taught from day one. Time is brain. With stroke, that time is very short, and there's a lot that can be done, but only in a short period of time. But we kind of lose that perspective when it comes to other neurologic diseases. With multiple sclerosis, you think, you're only 20, you're only 25, you have plenty of time, we can wait, we can think about it, we can wonder. Well, you know what? While you're waiting and wondering, you're losing brain tissue. Same thing with Alzheimer's. If you're able to pick up somebody's risk for Alzheimer's and they have a 90% chance of developing it earlier than one would expect, could they be on a preventative therapy? Or could they be enrolled in a clinical trial before they even develop symptoms to save brain tissue? So I think that's where the field needs to go. And again, I'm not a cognitive specialist, that's my disclosure, but apps like this, where we have these wearable devices, we have the Fitbit, you have the Apple Watch. This was also medicine of tomorrow, by the way, because this just got approved. We have these monitors. You can pick up if somebody has high cholesterol. A 30-year-old with a cholesterol of 300 is not going to kill them at 30. Might they develop a heart attack earlier than some? Yeah, but that's why you treat before it happens. You treat them when you realize that cholesterol is high. Why is a 30-year-old having their cholesterol checked? Because they have a family history, right? Family history of early heart disease, early stroke, early heart attack, early coronary artery disease. You treat early, you check early. Same thing with mammogram. You know somebody has a family history of breast cancer early on, you check, you monitor, you prevent. It's all about preventative medicine, right? So Benjamin Franklin, an ounce of prevention is worth a pound of cure, I think is the quote. We're not there yet in neurology, and I don't know why. For the life of me, can't wrap my mind around it. But it's the same thing with the brain. If we can predict who will develop these devastating neurologic conditions, we can prevent it potentially. But our clinical trials are not there yet. So in terms of that, the clinical trials, by the time you're enrolling somebody with a neurologic condition, chances are it's too late. With these Alzheimer's trials, you need to pick it up early. Once you know that there's something wrong, once the family realizes and take them to a neurologist, it's too late. So with MS, that's where we used to be with the field of MS. That's where, unfortunately, a lot of my colleagues still stand in the field of MS, where, you know what? Sure, they have relapsing remitting disease, but they'll be fine for the next 20 years. But you know what? I want that person to be fine after the age of 40 also. I don't want them to develop dementia at 40 or develop a gait dysfunction and start walking with a cane at 40. I want to prolong that as much as possible. So that's my theory. One of the reasons that I helped create this app is, I'm sure you can see the memory test. A lot of these things are designed to be fun games, but they're memory tests. This Stroop test, coding test, they're challenging memory games. And so it's not just something that can pick up a decline in cognition for MS, it's something that can pick up a decline in cognition for a lot of neurologic conditions, Alzheimer's being one. And that's something that we just have to make that transition to the general public. They care about worst case scenario. Do I have this? Do I have that? Do I have the zebras? And I'm sure everyone listening wants to get people focused on is, how about you worry about the horses? You know, we all develop mild cognitive impairment at some point. After the age of 75, I think you have a 10% chance per year to develop some form of dementia. And a lot of people have those senior moments before that. Sometimes I listen to what my patients are telling me of where they're putting different objects, and I keep thinking about the time that I put Windex in my refrigerator and a roll of toilet paper, I think, under the kitchen sink. So I meant to put the Windex under the kitchen sink, the toilet paper, I hope not in the refrigerator, but it's possible. That's what I was thinking too. Postpartum brain fog, right? So, but those senior moments really do happen, and it happens more when you're stressed and when you're fatigued and when you're living in a global pandemic, seeing patients and homeschooling your kids at the same time. And instead of people worrying about ways to improve their overall cognitive health, they're Googling zebras. So hopefully, as the medical community, we can continue to try and educate the general public. I think it's great when patients come in and they're wearing their Fitbits and they're wearing their Apple Watches. The question is, do they know what to do with those vital signs? Do they know what those vital signs mean? Chances are they probably don't, but hopefully there'll be some fusion of medical knowledge and I can't say patient awareness, lay people awareness at some point. So here, this is also medicine of tomorrow, telehealth. Here we are, telehealth. Some people love it, some people hate it. I think it's a double-edged sword. I think when used properly in the right hands, and when I say in the right hands, I would hate to be 1 year out of training, trying to make a diagnosis over telehealth. It would be near impossible for me after training or even training during this telehealth world. I see what our fellows are going through. I think half of their clinic is via telehealth, and it's such a huge disservice. I worry about my children with Zoom school. I worry more about the next generation of physicians that are learning via telehealth. And it's nothing to students and residents and fellows that are learning. I still would put my life in their hands, but to not, as a neurologist, to not put your hands on a patient, to not see a patient, it's extremely, extremely difficult. I still will I go in even before I was vaccinated, like I'm sure many people listening today. Before the vaccine, we were still seeing patients. For me, I was doing 50-50. And even when on the East Coast, when everything was in lockdown for 3 months, there was basically no procedures happening, elective procedures. Even emergent procedures was taking a backseat, which is scary. But the hospitals were flooded with COVID. Everything was COVID. So there were some patients that I still had to go in and see, those that needed their baclofen pump refilled. Otherwise, they would end up in the hospital or dead. I went in to see. There were some patients that I kept pushing off, like their Botox for spasticity or migraine. And I'm never going to forget this one patient where she couldn't figure out how to do telehealth. So I did a phone consult, which is pretty much useless. And she said, my migraines are terrible. My migraines are terrible. I really need my Botox. I said, okay, fine, come in. We'll do your Botox. And this was probably June, July. And her eyes were covered like many headache patients are because of severe photophobia. She was wearing these heavy sunglasses. And I said, I'm sorry, I need to examine you. I haven't seen you in 6 months. I really need to examine you. And she's like, why? Leave me alone. The noise is hurting. My eyes are hurting. Can you just give me the Botox? And I looked at her eye, pus draining from her eye. I took pictures just to show medical students and residents why an exam is so important. Pus, I kid you not, dripping from her eye. Where's her pain? Right behind the eye, on that right side, where it always is, Dr. Stoll, where it always is. Wasted the 200 units of Botox. And I said, absolutely not. You're going to your primary care doctor, your infectious disease, or your ophthalmologist, you pick, because she had all of those specialties lined up. And she couldn't understand why I wasn't injecting her. I'm like, have you looked in the mirror? No, she hasn't looked in the mirror. Why would she look in the mirror? She hasn't left her house in 6 months. But that's why it's so important to not forget that exam portion. And as much as we want to say, especially for our older patients, our handicapped, our disabled patients, okay, fine, you don't have telehealth, that's fine. A phone call will do. A phone call in some of these patients will just not cut it. And we can't forget that in this new norm of society where I'm giving lectures over Zoom, and I'm seeing patients over Zoom. There's certain patients that we just cannot forget about. And the same thing with teaching the future medical providers, the importance of it, because in our field, in today's society where this is the norm and this becomes the standard of care, it's scary how many things are going to be missed. So medicine of tomorrow, we still have these things that I kept as medicine tomorrow, still not available yet. So this is a device company that I was working with to help try and launch. So this is basically it's great, but it's funny. It just now hit me that everyone would use it for COVID. It's basically for COPD, chronic asthma, CHF patients. So the bounce back crew, right? Those patients that they come to the ER, they have COPD. You don't want to admit them, because if you admit them, you can't discharge them before 3 days or you get dinged. And you can't OBS them because, again, then you have to admit them for 72 hours or you don't get paid. And you can't keep them in the ER more than 4 hours, or the ER gets dinged for having a patient there more than 4 hours. So for all the students that are listening, all of these politics that are in healthcare, it's just, I mean, you have to take a medical course just on the politics of healthcare to get through it. Sometimes it's not about what's best for the patient, because nowadays you're keeping somebody in the hospital for 3 days just because of a COPD exacerbation, and you don't want to get dinged for discharging them early or admitting them prematurely. You're taking up a bed, and then they could become infected with COVID when they didn't come in with COVID. Although now if somebody comes in with a COPD exacerbation or CHF exacerbation, I'm sure they're going to be marked as COVID anyway. But this medical device is basically for those patients that you're worried about, but you don't want to admit them, because you admit them, they're going to get stuck in the hospital with something else like a DVT or an infection of UTI, which happens all the time. You want to get them in, you want to give them the steroids, you want to get them out, or you want to get them in, give them their Lasix, get them out, but you worry about them. So this is a device that basically, it's like a flat egg that sticks with tegaderm right under the chest and monitors their respiration, their coughing, and their wheezing. And it records that. And if there's a certain amount of coughing or wheezing per minute, it sends a signal to the primary care physician that this patient needs a phone call. And it sends the signal early enough to prevent that repeat ER visit, to prevent the bounce backs. That if somebody leaves the ER, they're back within 30 days. Or I guess they're discharged from the hospital, they're back within 30 days, because that also happens. And then you get dinged. So that's the point of this device. And of course, COVID came and everything with shortness of breath turned into COVID. But hopefully when COVID is no longer an issue, this is a project that's near and dear to me and I can take up again to prevent those bounce backs. Medicine of tomorrow. Now I'm coughing. So AI for health, artificial intelligence. Who here is familiar with artificial intelligence? So this is something that a lot of people throw around, have no understanding of what it is. Because of the app that I've been working on for multiple sclerosis, I have a little more than no knowledge of AI, but it's a cool concept. And it's just as scary as what they talk about in movies of the future. And I'll get into it more in the next slide. The accelerating medical research to advance prevention, diagnosis, and treatment of disease, that is something that we need desperately in the United States. Global health insight, increasing shared understanding, mortality, longevity globally. I think this is something the pandemic has actually sped up. Now, and also one of the reasons the pandemic has helped sped it up is because now it's a social norm to do everything on Zoom. I don't know how many meetings I've had with people that have been falling asleep on the other end. And I'm like, oh, you know, do you need a shot of caffeine or something? Like, are you okay? Am I really that boring? And they're like, no, it's midnight for me here. And I'm like, oh, wow, I'm sorry. Why didn't you tell me? You know, I probably could have scheduled this earlier. And they're like, no, because then we can't get the West Coast people on the call. And so with the social norm of having a call or a Zoom lecture with group in Germany and LA and New York. Let's see if I have any water back here. Nope, of course not. I have the Mr. Potato Head to keep me company, but no water.
Want to take a water break?
No, that's okay. Yes. Give me 1 second.
We'll just talk about the future of the medicine in the meantime. Okay. Just to remind everyone, if you have questions, feel free to use the Q&A box, and I'll be monitoring all questions as they come in, and we'll get to them at the end.
Okay, I'm back. Okay, so a few of these things we're starting to see come to fruition, which is really cool. We're more of a global medical community now. When the pandemic first hit, we were all logged on to what was going on in Italy, what was going on in the UK, what was going on in Spain, what was going on in San Francisco, because it was hitting them first. And all of the medical groups that I'm a part of, I tuned into and I listened very, very closely what was going on in their hospitals with the MS world. As a MS neurologist, I knew how to treat MS with COVID and what to do with all of the immunosuppressants that we use in our specialty because of what was being published out of the MS groups in Italy. And actually I'm the medical director for Yale's annual MS course. Our speaker, our main keynote speaker is the statistician or the epidemiologist that does all of the MS data for Italy, which is really cool. I would have never known her. My group would have never known her. We would have had no idea what was going on there if not for, I guess, the moral globalization of healthcare. It was something that was always available in Europe amongst European countries because of socialized medicine. The UK, Germany, Sweden, it was like the world's greatest data resource where the government has all of your health records. And because of that, you can do any clinical trial on any subgroup of disease that you want, which is really, really cool, kind of scary, but really cool. In the US, we couldn't do that. It took 40 years just to get an accurate number of the amount of people living in the United States with multiple sclerosis. That's how long it took, because we don't have the same kind of records as European countries have. But now, a lot of that is being shared more openly, not just amongst Europe and the US, but amongst other institutions in the United States. There's more collaboration amongst other institutions, amongst other groups, because it's a social norm now to have a conference on Zoom, to be available. I can invite speakers. Our organization, we can invite speakers from everywhere. We can invite people from everywhere to give talks because this is the norm. 2 years ago, we would have never even considered going to having a grand rounds at 8 o'clock at night, or for me, going to grand rounds at 8 o'clock at night. So that's something that's really, really cool that I think we would have gotten there, but the pandemic sped it up. And then health equality. So reducing health inequality, improving access to care for underserved populations. I'm going to leave it at that. And then medicine of tomorrow, again, Wise Eye AI, another company I worked with, basically looks to replace radiologists. I can tell any radiologists listening, they're nowhere near what they need to be to replace radiologists. So radiologists definitely still have a field. But what this was, or what I was trying to help the company work on, is narrow down what is needed in certain subspecialty fields. So for MS, there aren't that many neuroradiologists. I mean, first of all, 10 years ago, would you even consider having a radiologist that specializes in neurology? Like, first of all, anyone can see a stroke, or a neurologist could see a stroke. But now with the technology, I don't even understand some of the radiology sequencing or MRI sequencing that's being done. Really, really fascinating stuff. But what this does is, if anybody's seen a report where there's a differential that has, I always joke with my husband, he would say small sampling and then list 20 different things. So that's what a lot of us are familiar with radiologists. It's a differential, and then it has everything under the sun that can happen in the brain, or anything. It doesn't happen as much with the body, thank God. You guys are lucky. But with the brain, it's everything. There's one small spot in the brain. Differential includes infection, vasculitis, stroke, microvascular disease, MS, demyelination, ADEM, which is ridiculous, tumor, lymphoma, literally, they'll have everything in there. And basically what this technology does is narrow down the likelihood of what it could be. It's greater than 50% chance that the differential is X. But of course, the differential diagnosis can still include the other 9 items that you want to put on there, but it gives the likelihood that it is that first one. And that's all it does. How cool would it be to have a program that does that? That kind of takes away some of the responsibility of the radiologist, and not the responsibility, I should say the lawsuits, because that's something in the US that we still haven't been able to get rid of, or at least in the state of Pennsylvania and New York. Texas found a way, good for them. But now, even if we know what it is, you still can't eliminate the other possibilities, because you can get sued over that. You can get sued over your 90% chance that it's one, but it can still be one of the others. So hopefully the medicine of tomorrow includes tort reform. And that's it. Thank you. Questions? Sorry to paint such a grim picture of the future, but there are some bonuses of what the pandemic has brought us, like this.
Yes, thank you so much. I really learned so many new things. One of them is that I shouldn't Google my senior moments because it sounds like they might not be so unusual, especially given all the stressors that we're all dealing with and my age. So thank you for that and for everything else. I had a question come through that is a great question, and it's about how you got into app development. And I'm going to expand on that. With your focus on the importance of communicating directly to the public in a way that was never really an integral part of medicine, in previous years. How did you get into sort of the media part of your career? So a double question: how'd you get into app development? How did you get into media outreach and being a spokesperson?
So media is a funny story, because that I was pushed into my senior year of residency. I think I was like, I was in and out of lucid periods because I just had my second kid. And I let one of my co-residents convince me to do a fellowship at ABC News headquarters in the city. And she basically said, oh my God, you'd be perfect for this. You should totally do it. And I'm like, you're crazy. Why? And I started reading about it and I was like, wow, this is really, really cool. And this is something that, you know, things that you see happen and then you get stirred up about on the other end and you're like, oh my gosh, they're terrible. I can't believe this is happening. Oh my God, what kind of world do we live in? You know, I mean, now there's
Absolutely, yeah.
10 things that are on my mind right now that I'm thinking of right now that's just getting me riled up. So misinformation by the public and perpetuated by these medical media outlets was one of the top things on my list of things that would get me riled up, and still do. And I guess without realizing, I complained about it enough during residency that she's like, well, now you can actually do something about it. Why don't you apply? And I'm like, all right, fine, I guess I'll apply. It's not like I'm going to get it. And I got it.
That's
And
incredible.
I was, one of the reasons I ended up at Yale for fellowship was because my mentor / the chairman of our department was just such an incredible human being. I can't even, countless stories of what a mensch he is. And one of the things that he did was, part of this fellowship was part of the ABC medical media internship, fellowship, whatever, I would have to take time away from my fellowship. So he said, okay, so I was like, I'll extend my fellowship. And he's like, no, you're not going to do that because you're going to start faculty here July 1st. And I'm like, okay, let's not get crazy. And he said, listen, your 4 weeks vacation, instead of your 4 weeks vacation, how about you do that? You do your ABC News thing.
Wow.
I said, yeah, but there's Rosh Hashanah, there's Yom Kippur, there's Pesach and Sukkot. I mean, there's so many Jewish holidays. Like that's what I use my vacation for. And he's like, he's Jewish, not religious, not observant. He's like, listen, they get Christmas and Easter and God knows what else. Why can't we get Rosh Hashanah and Yom Kippur and Sukkot and Pesach? And I'm like, oh, so that doesn't count for my vacation? And he's like, no, that's a religious exemption. What are you talking about? And I'm like, oh my God.
That's just incredible.
Yeah. So that's how that started. And then I fell in love with it. I just literally fell in love with it.
And you're so good at it. I'm sure you found your calling to some extent and being able to combat the misinformation and etc. How about the app development? So
the app development was, that was just like an incredible Beshert story, if there ever was such a Beshert story. But basically, one of my colleagues at Yale, who's a headache specialist, her sister died of breast cancer from BRCA, and her husband, her brother-in-law, wanted to do something in memory of his wife who passed away. And he's this brilliant coder. And he met this other guy who has a VC company who wanted to do something to what is it?
In her memory?
In memory of his mother who just passed away from multiple sclerosis.
Okay.
So so they named it B Care for Beth, his wife, his late wife, and multiple sclerosis for the VC guy's late mother. And then my colleague who I work with every day that specializes in headache was like, oh my God, you're so passionate about this. Can you be on the board? And I'm like, sure. Well, first, let me see the product. Before I want to join something, I want to understand it, right? And once I saw what it did, I was like, oh my God, this is incredible, but let's tweak a few things and take it to the next level. And then people started bringing me these other projects, like that half an egg that you put under the lung that, with COPD and CHF, not that I have anything to do with COPD or CHF, but it's that taking it to the next level. What is it missing? so people just started approaching me with these devices and these apps, and that's kind of how I got involved.
That's so cool. And I would add one thing. I think what I really hear from you is flexibility.
Yes.
And, I remember when I was in medical school, my mentor telling me that, half the things going on today, we didn't learn about in medical school. And I think it's not just the diseases that come up in COVID. I mean, nobody knew about COVID, when I was in medical school or even 2 years ago, but just the ability to adapt to medicine as it evolves as a field. I certainly never thought I'd end up as a regulator, but, keeping an open mind. Thank you. I mean, it's been so fun and such an interesting journey. I think keeping an open mind to things that spark your passion and interest as you progress through your medical journey. I mean, that's only going to serve you well as medicine evolves going into the future, et cetera.
Yeah.
So we have some other really great questions. I'm hoping we can get to some of them.
And wait, just before you get to those, the one thing that I wanted to add is, especially as a woman, especially as a frum woman in medicine, the one thing I never, ever, ever thought I could do is ask for something. I already ask for so much. Maternity leave, being pregnant, having a kid during residency, during medical school, during internship, just being married, you're like a novelty, you like stick out. And then on top of that, I just had one of my colleagues say, I'm like, oh yeah, no, I'm taking off for Passover. And she's like, oh, don't tell me it's to spend time with your kids. And I'm like, okay, all right. No, it's not to spend time with my kids. I see them enough. It's because I have to.
Yeah.
I literally cannot drive or turn the light on or off, But like just even getting that from another mother, she's a mother too. It was really just like, it's
unbelievable.
So just learning that I'm good enough, then I could ask. Worst case, they say no. Worst case, my chairman, my mentor said, no, you can't take 4 weeks off to do a medical internship at ABC News, right? That's the worst that could happen. The best thing is he says yes. So that's something that I hope I leave with, everyone understanding that all it is a question. Okay.
Well, that's incredible. And thank you for sharing that confidence that you found. I think that's also something to keep in mind, not to be apologetic or afraid. You're incredible. You didn't get to where you are without being outstanding in your own way. So take advantage and, use your leverage to get something that, is not such a big ask when it comes down to it.
Yeah.
So we have another question. Given the technological advancements in the future of medicine, what do you think medical trainees can do today to remain relevant and innovative?
Oh, that's a tough one. The path that we set forth for you guys is not the path to take. I remember when I was applying for medical school, people told me, and this was already once I did my prerequisites and I had my major and I did all of that stuff. And then I was applying. And then the times were changing and they said, oh no, in medical school, they don't want you to, have a major of biology. They want you to do like English literature because they want you to be well-rounded. Or they don't want you to volunteer in a hospital, which of course I did. They want you to do X, Y, and Z, or they want you to, be in an orchestra. Again, for this well-roundedness, right? I'm sure you've heard this.
Right.
But of course, what people were telling me was that you need to volunteer, you need to major in biology or chemistry or orgo, otherwise they're not going to look at your application. So what advisors are telling you now, you have to take with a grain of salt, and you also have to realize how up to date they are on their medical knowledge. So one of the questions that we always get now is, oh, can I shadow? Can I shadow? Can I shadow? I need a letter of recommendation. So can I shadow you? That time is up. There's no more shadowing. We can't even have medical students shadow us, or residents shadow us. Everything is virtual. So anything that you can do to make yourself unique, stand out, and also, like whoever that asked that question, that's a fantastic question, is you find something that you care about, that you're passionate about, that will make a difference moving forward, whatever it is. don't let someone tell you what your passion should be. And it doesn't have to be 10 things. If it's 10 things, until you find that one that you care about, great. But in an interview, or in an interview for medical school, for residency, for fellowship, no matter what it is, you're going to know your passion more than them. The only thing that will come through is how much you care about what you do. And that's what they're looking for. They're not looking for you to be passionate and care about what they care about. No one's going to do that. So it's not about staying up to date or finding or trying to figure out what the next Google or Apple or Tesla is going to be. Or now, what is it? Game station? Play game?
Gotta ask my kids.
No. Did you hear about that stock that like?
No. Oh, that one. Yes.
The guy made like $33 million on a company that should have been extinct with Blockbuster.
Okay.
No one's gonna give you that magic 8 ball of what it's going to be in the future. It's what you care about and how you can move that interest forward. I hope that makes sense.
Yeah, this is great. Thank you so much. And we're really at the end of the hour. I'm going to leave you with one question coming back to the topic of tonight's lecture, and maybe you could give me one line to end this lecture. If you could go back to pre-COVID medicine right now, someone waves a magic wand, COVID is over, you can go back to clinic the way it was a year ago. Would you, wouldn't you, and why or why not? In a couple of sentences.
Yeah, no, that is something I think about literally every single day, because my presentation, the slides didn't change from a year ago. The only thing that changed were the titles on some of the slides: the telemedicine, the telehealth, the medical apps, the medical devices. That everything else stayed the same. The thing that COVID did was speed up what I wanted to happen anyway. So for the question before, what was the new thing that was going to happen? It was telemedicine. I was screaming from the rooftop, telemedicine, telemedicine, telemedicine. We need it now. We needed it yesterday. We need it tomorrow. And February 11th, when I wrote it, the year of tomorrow, and there were 3 companies that approached me for telemedicine, bringing telemedicine to Yale. And I already had those meetings with with the business team at Yale to bring telemedicine to neurology. And I was told
you were ahead of your time.
I was going to be the first person in neurology to use telemedicine. And it's because of that. It's because my patients were coming from God knows where, getting on a plane, seeing me for routine care. Routine care doesn't cover an acute relapse. It doesn't cover somebody's decline over a 6-month period. I can't see that. I can't predict that in a 30-minute clinic slide. Telemedicine allows us to have appointment visits between the appointment visits. I can keep a closer eye on my patients. A lot of my patients have dementia. I need to see them every 2 weeks because I can't give them 3 medication changes at once because they can't remember the first medication change. They can't remember to call me if there's something wrong with the first medication change. So the conversation 3 months later is, oh, hey, how's that Lyrica that I prescribed you? Oh, it didn't work, so I stopped taking it. Well, did you ever go up on the dose? Oh, no, I just took it a few nights and it didn't work. I'm like, do you remember I told you that you have to titrate up? Oh, no, I can't remember that. And we all have patients like that. So that's what telemedicine has done for the MS world. And I'm sure it's done that for endocrinology and rheumatology and cardiovascular disease, because patients can't remember their meds. Not their fault. I have my senior moments where I put my Windex in the refrigerator and they have more issues than I do. So to have that reminder goes a long way, and we're able to do a better job of taking care of our patients. So that's something that I literally, the way I treat patients now in my clinic, this is where I saw the field moving, or this is where I saw medicine moving a year ago. The only thing that COVID did is it sped up that process.
That's pretty incredible. And thank you very much for putting such a positive spin on something that is otherwise so horrific
Devastating
and
and tragic.
life-altering.
Yes.
I think any positive takeaways we can take from the experience we've all lived through collectively as a society, and certainly as physicians,
Yeah.
is incredibly valuable.
I look at COVID as pregnancy and that first 6 months postpartum. Afterwards, you're left with this baby, and you're like, oh, wow, this is great. You know, oh, yeah, no, it wasn't that bad. But during, you're like, what was I thinking? I'm never doing this again. This is the worst thing I've ever been through in my life. How does anyone have more than one kid? How does anyone even have one kid? I don't think any of us are going to go back and look at COVID as like, wow, that wasn't that bad. I'm sure some of us will. Wow, wasn't that bad? But none of us will want to go through it again. That's for sure.
Yeah, no, thank you. And you know, I think you've given us some really interesting food for thought. I know in what I do, we're talking about clinical trials and what they're going to look like going forward. We're talking about workplaces and what they're going to look like going forward, not just in medicine, but in other settings as well.
Yeah.
So thank you for your optimism and for your perspective and for sharing all of your experience with us. And I'm sorry to the questions that we didn't get to. They were great. We just had a finite amount of time. And thank you so much to the organizers of these grand rounds and to Dr. Stoll for joining us. And I hope you'll join us next month for our next grand rounds. And thank you so much. Have a great night, everyone.
Bye. Thank you.
Bye.